Hello everyone and welcome to our module on granulomatous inflammation. In another video I talk about acute and chronic inflammation, but by way of review, acute inflammation has a rapid onset, often in minutes to hours, and it usually resolves quickly within a couple of days. In contrast, chronic inflammation, as the name implies, is chronic and it can last for weeks, months, or years. Granulomatous inflammation is a subtype of chronic inflammation. It's a special form of chronic inflammation where structures called granulomas form. That's how it gets its name. Key cell types in granulomatous inflammation are, first of all, macrophages. Macrophages are heavily involved in this form of chronic inflammation, and they transform into two cell types. One is called the epithelioid cells, and the other is called Langerhans's giant cells, and we'll talk about what both of these are in just a minute. Also very important to granulomatous inflammation are T cells. T cells are often involved in this type of inflammation, and this is an example of a T cell mediated hypersensitivity reaction. In the immunology videos, I talk about the four traditional types of hypersensitivity or immune reactions. The fourth type, the so-called type 4 or delayed type, involves cells. It's called cell-mediated immunity, and it can involve cells like T cells and macrophages. And granulomatous inflammation is an example of type 4 hypersensitivity. Basically, what's happening in granulomatous inflammation is that there is something the body is trying to remove. Maybe it's a bacteria, maybe it's a foreign body, but it's very difficult to eradicate. As a result, macrophages are stimulated, and they ultimately transform into different cell types, and those cell types form structures called granulomas. This is a picture of a granuloma shown on the screen here, and it's basically got three components. The first component are called epithelioid macrophages. These are large pink activated macrophages, and they get their name because they look like epithelial cells. These are shown in the center of this drawing on the screen here. These pink cells here are the epithelioid macrophages. Second cell type in granulomas are lymphocytes. Sometimes they are also plasma cells, and those are these dark cells surrounding the circular structure of the granuloma here. And then finally, sometimes there's so much stimulation of macrophages that the epithelioid macrophages fuse and they form what's known as a giant cell. This is a giant cell right here. You can see that it contains lots of nuclei. Some giant cells can contain 20 or more nuclei. So those are the components of the granuloma. They're all a result of heavy macrophage stimulation due to something driving the immune system that cannot be stopped easily. And here I've zoomed in just to make this more clear. These are the epithelioid macrophages. The ring of lymphocytes is around the outside, and this is an example of a giant cell shown here. The type of T cells that are usually involved in granulomatous inflammation are Th1 CD4 positive T cells. In scientific journals and in textbooks, you will sometimes see it written that there is a high CD4 to CD8 ratio, and what this means is there's lots of CD4 positive Th1 helper cells. In addition, there are two cytokines that are key to granulomatous inflammation, and you need to know these for step one. The first one is IL-2, and the second one is interferon gamma. IL-2's role is to stimulate proliferation of the T cells. Interferon gamma's role is to stimulate macrophages. And working together with the T cells and macrophages, this is what leads to granuloma formation. And an easy way to remember this is just to remember the word granuloma. It has the two cytokines in its name. Interferon gamma is around the G and IL-2 is around the L. Shown on this slide are a number of granulomatous diseases. There are many more than just what's on this list, and all of these are chronic conditions. You're not going to see granulomatous inflammation with an acute infection that resolves in a couple of days. It's going to be some disease process that smolders on for weeks and months, leads to chronic inflammation, and then this special form of chronic inflammation called granulomatous disease. Tuberculosis is a classic cause of granulomatous disease, so is sarcoidosis. In fact, finding granulomas on a biopsy is one of the diagnostic criteria for sarcoidosis. The rest of this slide are some other conditions that cause granulomas. These are ones I think you should know for step one, but there are many more than what's on this list here. There is one special form of granulomatous disease that it's high yield for you to know for step one because it has an important tie-in with cellular biology and biochemistry, and this is called chronic granulomatous disease. And as you can imagine, in this disorder, lots of granulomas form. The underlying cause of this disorder is a loss of function of the enzyme NADPH oxidase, and because of this, phagocytes like macrophages cannot generate hydrogen peroxide to kill bacteria. And I talk about this in more detail in the video on free radicals. In that video, I explain how NADPH oxidase is important for the respiratory burst inside of macrophages. The consequence of not being able to generate hydrogen peroxide is that patients who have this disorder develop recurrent infections, specifically recurrent infections with catalase-positive bacteria. There are 5 organisms that cause almost all infections in chronic granulomatous disease, and I've written them on this slide. There are 4 bacteria and 1 fungi. All of these organisms are catalase positive. So if a person is born lacking function of NADPH oxidase, they are susceptible to recurrent infections with these organisms, and as a result, when they get an infection with one of these organisms, they often form granulomas at the site of infection. That's why it's called chronic granulomatous disease. There's a special subtype of granuloma called a caseating granuloma, and it gets its name because when this process is occurring on gross pathology of an organ, what you will see is this cheese-like material caused by cheesy-like necrosis. That's what the word caseating means, is cheese-like. If you look at the bottom left side of the screen, this is a lung from a patient who had tuberculosis, and you can see this white cheesy-like material here, and that is the result of caseating granulomatous inflammation. The classic cause of caseating granulomas is tuberculosis infection, although there are a few others. Most granulomas, however, are non-caseating. For example, sarcoid is non-caseating. And if you look at the bottom right side of the screen, the reason this cheese-like material forms is because in disease processes that lead to caseating granulomas, a large area of necrosis forms at the center of the granuloma, and that necrosis is what gives rise to the cheesy-like material that you can see on gross pathology. Earlier, I mentioned that IL-2 and interferon gamma were very important in granulomatous inflammation. Another important cytokine in granuloma formation is tumor necrosis factor alpha, or TNF-alpha. This cytokine has been shown to maintain granulomatous inflammation. It's released by macrophages and T cells, which, as you know, are the cells involved in granulomas, and TNF-alpha has been shown to attract and stimulate macrophages that, as you know, are involved in granulomatous inflammation. This has clinical relevance because there are TNF blocking drugs that are used in some conditions. These are anti-inflammatory drugs used in rheumatoid arthritis and Crohn's disease. For example, infliximab is an anti-TNF antibody, and Interacept is a decoy receptor to TNF-alpha that also blunts the effects of TNF-alpha. So if you are going to give a patient one of these drugs, you are going to block the ability of the body to form granulomas. That means if the patient has tuberculosis, which is latent in their lungs, it may reactivate because you blunt the ability to form granulomatous inflammation and contain that tuberculosis infection. So for that reason, PPD testing, which is a screening test for latent TB, is always done prior to starting therapy with one of these drugs. TNF-alpha is very important for granulomatous inflammation. It's also very important in fighting off intracellular organisms. So for both of those reasons, when you block it, tuberculosis has a high likelihood of flaring if you have latent TB inside of your body. Let's finish by discussing hypercalcemia. This is seen in many granulomatous diseases, although it's best described in sarcoidosis, and sarcoidosis is the classic condition to cause hypercalcemia. To understand this, you need to appreciate that activated vitamin D is normally produced only in the kidney, and in that location it responds to PTH, so the parathyroid gland controls the amount of activated vitamin D. Some macrophages have high activity of the enzyme 1-alpha hydroxylase. This is the same enzyme that's found in the kidney, which can convert vitamin D into its active form of 1,25-OH2 vitamin D. What this means is when you have lots of active macrophages, just like you do in granulomatous inflammation, this enzyme can become very active, and in macrophages it is not under the control of PTH, so that leads to excessive amounts of activated vitamin D, which is also called calcitriol, and this is the mechanism by which hypercalcemia can occur in granulomatous diseases. And that concludes our video on granulomatous inflammation.